Okay, so this is chapter 20, and we're going to talk about heart failure and circulatory shock. Okay, so a couple of quick. First of all, heart failure is just that, it's heart failure. A lot of times we talk about heart failure as being a lack of perfusion, but initially, even though you have heart failure, so even though the heart is failing, the there are compensatory mechanisms that will keep the perfusion going, which a lot of times can mask a lot of the heart failure that's going on in a patient, and they don't realize it until much later stages. So during heart failure, the heart does not adequately pump blood. Okay, so pumping, or does not adequately fill with blood. So what we're saying here is that's going to be systolic, because systolic is, or systole is the contraction. So that may be affected, or it could be a valve issue. But somehow it's not pumping out enough blood, or it does not adequately fill with blood. So that's going to be diastole. Okay? Diastole. And so that means that when it's relaxed, diastole is relaxation. We're talking about the ventricles here. Uh, Relaxation of the ventricle, and so it's not able to take on enough blood. So failure can be systolic or diastolic. It can be classified as left side or right side. So left side being, of course, oxygenated, which is going out systemic from the ventricle, and right side is going to the lungs. So ultimately, the heart, and this is the problem, ultimately, the heart cannot meet the metabolic needs of the body. So once these compensatory, so the heart is failing, compensatory mechanisms kick in to keep that perfusion, and of course, perfusion is just the ability to kind of, so if you have your blood, the ability for fluid to move around the cells and give them their nutrients. So that's perfusion. Okay. Ultimately, the heart can't meet the metabolic needs of the cell, so some of this goes away, and it's just, and your cells can become starved. Okay. All right. So remember, ventricles have to fill and relax. So remember, the Frank-Starling mechanism shows that as they fill and as they relax, they take on blood, and that's preload. So the amount of blood that they take on, or your end diastolic volume. So as the ventricle relaxes, and blood will flow in passively, and then the ventricle will give it that extra kick, uh, the atrial kick, which is active filling. But either way, they fill with blood as the ventricle is relaxing. So that's diastole. Okay? It's relaxing. It's filling with blood. And then and so the Frank-Starling mechanism. It sounds it's kind of, I don't want to say it's easy, but the concept is easy. It sounds very logical. The more blood that goes into the ventricle, the harder it's going to pump. The harder that ventricle is going to squeeze. So the more blood that goes in, the more blood it squeezes out. Okay, so that's kind of how our hearts work. If we have more blood volume, well, your heart can deal with that. It'll just squeeze harder. What it has to do with, though, is how the actin and the myosin, maybe this is where it can get confusing, is how the actin and the myosin line up. When you lift something that's heavy, your backpack, or books or something like that, you lift something that's heavy. Notice how I keep that all academic. Um, you pick up something that's heavy, you have better strength when it's kind of in the middle. Okay, so you don't have as much strength when your arm is very stretched out. Um, you have the most strength when it's kind of at a 90-degree angle. Okay, so whatever you happen to be picking up, you're going to have better strength in this area than you do in this area, and you're going to have better strength than you do if your arm, these are supposed to be arms. Okay, so these are your hands down here, and that's whatever. You're going to have the most strength when it's at about a 90-degree angle, and you're lifting the load. Well, the heart's the same way. You have the best myosin on actin contact right in the middle. Okay, so, and that's true for a range. So when it's very much contracted, so this would be like your arm was already flexed, it's harder to contract the muscle at that point. So when the stroke volume is very low, it's not really stretched, then it's not going to be as much. But then as it it stretches out a little bit, you have better contact of actin and myosin. Okay, and so it's going to be a stronger contraction. But we know that as it stretches out too much, okay, so this would be like trying to lift something with your arm almost fully extended, you have the opposite problem. Okay, and so that means that if your heart gets stretched out too much, let's say your preload is way too high, way too much blood is moving into the ventricle, it stretches out so much, then it's not even going to be able to squeeze as hard as it could have if there was less blood in it. Okay, so that's where the problem happens in here. But in this range, in this middle range, it sort of makes sense. More blood, stronger contraction. Okay, so we have these things positive, so we call these inotropic agents. So we do have medication, so if someone comes in and they have low contractility, low blood pressure, then there are things that can be given to increase the strength of a muscle contraction. So dopamine, norepinephrine, we call these positive inotropic agents. So that normally the Frank-Starling mechanism is working just fine in a healthy person, and so more blood means a stronger contraction. Okay, cardiac output. So we've gone over this, I believe, before. So cardiac output is stroke volume times heart rate. Now, stroke volume is just how much blood volume that is pumped out of the ventricle. So if this is our ventricle, how much blood are we pumping out? Okay, so if we pump out that much blood, then that's going to be our stroke volume. So we just focus on that. We say how much is that? What is the volume? That's our stroke volume. Okay, the reason I make a big deal about that is because we have something called ejection fraction, which is similar to stroke volume, but it's saying what is the proportion of this? I mean, did we pump out 60%? Did we pump out 40% of the blood, of our end diastolic volume of the blood that was initially in the ventricle? What percent did we pump out? But stroke volume is volume. Okay, and so we call cardiac output is going to be the stroke volume times the heart rate. So that's going to be a per minute. Okay, so it's really not that complicated. I always say that, but cardiac output is just how much blood you're pumping out in a minute. Okay, so that's going to be your stroke volume times your heart rate. Okay, so that's going to tell you how much. I mean, it's kind of like if you're trying to, I don't know, fill a bucket with water and you're using a little cup to do it. Okay, so how much water is in the cup and how many times can you dump the cup? It's going to tell you over a minute how much your stroke volume is in this case. Okay, not sure if that analogy worked. All right, so ejection fraction, like I said, ejection fraction is kind of another important term, and it's very much related to that. So if you're saying, well, ejection fraction is kind of like the same thing as stroke volume, except ejection fraction is going to be a percent, whereas stroke volume is going to be a volume. Okay, so it's going to be in liters. All right, so at rest, the left ventricle only ejects about 60% of the end diastolic volume. So that means the volume of blood that originally started out in your ventricle, okay, in a normal, healthy person, and they're at rest, they're going to pump out about 60%. Okay? So that's the percent or the fraction of blood that was pumped out. So that 60% is going to be your stroke volume. Okay, so whatever that 60% volume is going to be your stroke volume. But the difference is that your ejection fraction kind of depends on how much blood was there to begin with. Stroke volume is pretty straightforward. How much blood came out? Just measure it. We don't care how much was in there to begin with. We don't care if it's pumping out 100%. We don't care if it's only pumping out 10% with stroke volume. But with end diastolic volume, see, now we get involved with the ventricle. So now we can say, how efficient are you, ventricle? How hard are you pumping? How good are you at pumping out blood? Are you pumping out 100%? Are you pumping out only 10%? Are you weak? Okay, so that's kind of what we're going after, and that's kind of why we care about ejection fraction. We want to know how strong that ventricle is. Okay, so at rest, the left ventricle only ejects about 60% of the end diastolic volume. The end diastolic volume is about 110 to 120 milliliters, so that's about how much is in there to begin with, and making the normal stroke volume about 70 milliliters. So if we're healthy and we pump out about 60% of our end diastolic volume, or whatever volume that was right before it started to contract, or right before systole, then if it's 70 milliliters, if we're pumping out 60%, everything is just fine. So we'll talk about how that relates to pathology in just a second. Okay, let's see. So cardiac reserve is the ability of the heart to increase cardiac output during increased activity. Yeah. So yeah, when you're exercising more, you can maybe pump out instead of 60%. Yeah, maybe you'll pump out 70%, which is going to increase your stroke volume. Okay, so your heart rate may increase. And so that means that a healthy person can walk up a flight of stairs and be just fine. Okay? Yes, they're going to have a stronger demand. Their extremities, their legs are going to say, "Hey, I need more blood," but because your heart rate can increase, your stroke volume can increase, then you'll be just fine. So, heart rate, stroke volume, increasing heart rate and stroke volume during exercise can increase cardiac output up to 5 or 6 times in a healthy person. Okay, in someone with heart failure, that cardiac reserve is severely diminished. Okay, depending on how far along, how progressed the heart failure is. And so that means a person with heart failure may suddenly, when they try to go upstairs, they may not be able to perfuse blood to the tissues as well because their heart is pretty much already working as hard as it can. And so they may feel some angina because they're not getting enough oxygen to the heart muscles or to the rest of the body. They're going to feel kind of just worn out. Okay, so pathophysiology involves an interaction between a decrease in cardiac output. Okay, so that's how much blood you're pumping out per minute overall, with a consequential decrease in blood flow to the kidneys. So maybe the kidneys are trying to redirect blood so not as much blood goes into the kidneys, or maybe your heart just isn't able to pump as much blood, so the kidneys are going to get less. But it's not just the kidneys, it's other body organs as well. It just seems to affect the kidneys primarily, and we can use that kind of as a diagnosis because depending on your how much urine you're producing or something like that. So the recruitment of compensatory mechanisms are designed to maintain tissue perfusion. Okay, so the heart is going to work harder. So if your stroke volume decreases, now ask yourself, this is something you have to understand. If your stroke volume decreases, first of all, why would your stroke volume decrease? Well, your stroke volume could decrease just because the ventricle isn't working very hard. Okay, or I'm sorry, I shouldn't say it's not working very hard. It can't work very hard. Okay, so that means the ventricular muscle may be damaged or something like that. Okay, or it could be that it wasn't getting enough blood to begin with. Okay, so for some reason, either you didn't have enough end diastolic volume, or the ventricle just simply isn't able to pump what's in there out, but your stroke volume decreased. So how might you be able to compensate? Well, if we're trying to keep our cardiac output up and our stroke volume decreases, then we might compensate by increasing heart rate. Okay? So if we increase the heart rate, then we've kind of solved the problem from the perspective of the body. Yeah, the heart's working a little harder, a lot harder. And so how are we going to do that? We're going to increase our sympathetic output. Okay? So what division of the autonomic nervous system will have increased activity? The sympathetic. That's our fight or flight, remember? So our sympathetic activation is going to increase heart rate. Okay, sympathetic activation also tends to cause an overall vasoconstriction, okay, which increases blood pressure. Okay, so types of heart failure. You can have heart failure. So we're going to relate these heart failure and ejection fraction. So if it's systolic, okay, and I really hope you can understand this. If it's systolic, this is my ventricle again. This is my end diastolic volume. Okay, so that's as filled up as it's going to be my preload. Okay, so that's my preload. That's the volume that I've got after the passive filling and the atrial kick. That's as much blood as I've got in there. So if this problem is with systole, then that means that I'm not going to be able to pump the same fraction of blood out. Okay, so that means instead of 60% maybe of this volume being pumped out, maybe I'm only going to be able to pump 40% out. Okay. Okay, so that means that if it's systolic, heart failure with reduced ejection fraction. So that's what we're going to call that. So heart failure with reduced ejection fraction is usually a systolic problem. For whatever reason, whether it's because the heart muscle itself wasn't working as well or because of, let's say, a stenotic valve, it wasn't able to push it through. For whatever reason, that end diastolic volume, you're only pumping out about 40% or less of that. Now, what if we have heart failure? So the other one is diastolic, heart failure with preserved ejection fraction. Okay? So what if your stroke volume is decreased, you're not getting enough blood to the tissues, but you're still pumping out 60% of the blood? Okay? So you're pumping out 60%, but that's still a reduced volume. Okay? If that's the case, if you have a preserved ejection fraction, you're still pumping out 60%, which is normal, which is healthy, but it's still not enough, then that means that something happened with the filling. That means that your ventricle was not filled properly. And so it's saying, okay, I'm pumping out 60%, just like it says in the manual, but it's not enough blood. Okay, so that's heart failure with a preserved ejection fraction. So that's going to be diastolic. So that means somehow, for whatever reason, enough blood is not moving into the ventricle. Okay, so what that means is the heart failing to pump out enough blood, systolic, or failing to accept enough blood, diastolic, from the body or the lungs. And then we're going to separate these by right-sided or left-sided failure. Is the right side or the left side of the heart failing? And then you can also do, we're not going to really talk about it, but you can also say high output versus low output failure. Is the cardiac output high or is the cardiac output low? But we're going to focus on these first two right now. Okay, so again, heart failure with a reduced ejection fraction, HFrEF. We call this, or this is known as, a systolic failure. Okay, so we're moving sort of to call it this more because it could have to do with, a valve or something like that. But either way, our ejection fraction, okay, that ejection fraction, which is how much, if this is our end diastolic volume, our ejection fraction, what percent is being ejected out. Okay, so this is going to be, so ejection fraction of less than 40%, then that's going to overall decrease your cardiac output. Okay, causes could be contractile performance, so the heart can't contract properly. That could be caused from myopathy, some kind of pathology or disease of the heart. The heart muscle isn't working well. Okay, so that means that the heart muscle isn't working well. It could come from an MI, a myocardial infarction. Something is not allowing the heart to pump properly. Ischemia, so for whatever reason you're not getting good blood flow, some kind of a blockage or something. So a weakened, overall, it comes from a weakened or a damaged cardiac muscle. Okay. It could come from volume overload. So remember back to our Starling effect, our Starling mechanism, our Frank-Starling mechanism, I guess. It's called both things. So the Frank-Starling mechanism, remember how that works to a point, but then if it fills too much, it actually starts to fall off and it becomes less efficient. So if we're working over here in this range, so we have a really high preload. Okay, so preload is just basically how much blood is moving in. So that's going to be similar or the same as our end diastolic volume, except that's going to give us a number. Our preload is, let's see, a high preload causes a higher end systolic and higher end diastolic volumes because the ventricle is stretched so much it becomes less efficient. So that means that it's very much stretched, which is your end diastolic volume, and then it tries to squeeze, but it's so stretched out that it says, ugh, and it puts a little bit of blood out there, but it's not nearly enough. So your end systolic volume is still high. There's still too much blood in there. And so now comes more blood, and so you can kind of see how that can keep going. So it could be so this could be caused by a valve insufficiency. So let's say your mitral valve or whatever um, is not allowing is not holding the blood in, or something like that. So it could, a failing mitral valve could lead to this volume overload. Okay, let's see. You can't get the blood out. Let's see. Pressure overload, can't get the blood out, so that's being unable to remove it, and so that means that your afterload is going to increase. Okay, so remember, if your preload is how much blood you have in there to begin with, then your afterload is how much force is it going to take me to get that blood out. Okay, that's our afterload. If our afterload is really high, if you're putting it through, I mean, the aorta is usually pretty big. If you're trying to, the aorta is kind of, clogged up, hypertension, then you're not going to be able to move as much blood out. Okay, so hypertension, your semilunar valve may not be working properly. That may not be able to get the blood out. Okay, so I want to go back and talk about this valve insufficiency. Okay, so as it's trying to pump the blood out, okay, so I should probably say, I was talking about the mitral valve. It's actually moving through the semilunar valve, right? Semilunar valve. So a reduced ejection fraction, I kind of went off in a wrong direction there. If you're squeezing blood from the ventricle and this semilunar valve is insufficient, that means that as you squeeze the blood out, some of it is going to come back in. Okay, so that's going to reduce the fraction. Okay, I hope that makes sense, that I didn't confuse you too much. I'll say it again just because I kind of went in a wrong direction with that. So this is your end diastolic volume. Okay, and let's say this is your semilunar valve, and it pushes the blood out. Let's say it opens, it pushes the blood out, but if it's insufficient, and let's say we could even say for fun, yeah, it pumped out, a normal 60%. Yeah, it worked. It was fine. It worked fine. But if this valve is insufficient and it doesn't close properly, then let's say 20% of it just simply moves back in. Okay, so that means instead of pumping out 60%, yay, it's gone, and then a bunch of it just leaks right back in. Okay, that's going to be, that's what we mean by valve insufficiency for volume overload. Okay, so I hope that makes sense and clarifies that. Okay, all right, so heart failure with a preserved ejection fraction. Let's try to make this as simple as possible. Okay, I've already mentioned it once. Here's our ventricle. Here's how much blood. This is our end diastolic volume. And we pump out 60%. Fine. That's enough blood. So if this is healthy and normal, that's enough blood. Now, let's say that we don't fill it very full. Okay, here I'm actually going to draw this down here where you can see it. Let's say that we only fill it this much. Okay, so we don't have as much. We pump out 60%. So remember, we have a preserved ejection fraction. We still pump out 60%, but that's not enough volume. Okay, so we're still preserving the percent, which means maybe that the systole, the ventricle is working fine, but there wasn't enough blood in there to begin with. Okay, so that's why it's called heart failure with a preserved ejection fraction. 60% of not enough is still not going to be enough blood. Okay, All right, so the ventricles can't fill sufficiently during diastole, so the fraction that is ejected is normal, so it's over 50%. I use 60% as an example because that's normal. So it's over 50%, but the overall volume of blood being pumped is reduced because your end diastolic volume is reduced, which is what we see here. Okay, our end diastolic volume is reduced compared to normal. All right. Okay. So hypertension is the leading cause of diastolic dysfunction. Yes, if you can imagine things being pumped around and all of a sudden, or not all of a sudden, but over time, the ability for it to move through the tubing is reduced, then yeah, you're going to have less blood moving um, back to the ventricles. Okay, so hypertension is leading cause. Also pericardial effusion, so fluid builds up around the heart, compressing it. We call that cardiac tamponade. So that's what we see here. So whatever, some kind of an infection, some kind of trauma, whatever is causing fluid to build up around the heart, well, then when the blood flows into the heart, it's not going to be able to expand because there's fluid all around it. So it's trying to take on the blood, but all of this fluid is pushing in, saying, yeah, I don't think so. Okay, we're going to push in on you, and you're not going to be able to fill with blood as much as you want to. Okay, so that's a pericardial effusion, so blood flowing out into this around the heart. Okay, and we call that a cardiac tamponade. Okay. It's around the pericardium. All right, so increased ventricular wall thickness. So this shows a very dramatic picture of that. When you're, so let's say that you've been trying to pump blood a little harder for an extended period of time, your muscle gets thicker, which is going to decrease how much volume that you can actually hold. Okay, so even though blood is trying to move in to fill this, you just have such a reduced volume that that it's just not going to be enough. Okay, so increased ventricular wall thickness, so that's myocardial hypertrophy, reduces the overall volume of the ventricles. Pretty straightforward. If we keep, so if we look at the left side over here, if we're trying all the time, we're just working that heart muscle really hard all the time, it's getting thicker and thicker, because that's what muscles do when you work them. They tend to get larger. It gets thicker and thicker. Well, pretty soon you've eaten up some of that volume. And so let's see if we change the color of that. I think you probably already understand, but I guess a little bit of repetition doesn't hurt. Just wasting everybody's time. No, I'm just kidding. Oh, no, I'm not. Okay, so you're going to have less blood volume that's going to be in there. Okay, so, and also a delayed reaction time of ventricle. So delayed reaction of the ventricle, so delay in your systole or your diastole can reduce the time that it's filled. So that can come from a number of things like electrolyte imbalances or something like that. Okay, so note that hypertension is involved with both, okay, with both systolic and diastolic function. Okay, so left-sided versus right-sided. So clinical manifestations depend on which heart chamber is dysfunctional. Okay, and that sort of makes sense. Our left side and our right side have to maintain equal outputs. I hope that makes sense. So that means that the left ventricle and the right ventricle both need to pump out the same volume. Now the right ventricle is thinner, it's weaker, okay, because it only has to pump to the lungs. So it's under less pressure, okay? But the volume has to be the same. The right ventricle is thicker and stronger, okay? But it's going to pump out the same volume per beat, and it has to, because if it didn't, if the left ventricle, we think of it's going to the whole body, but because it's a closed system, if it's pumping out 100 liters per minute, well that blood is going to come back to the right side. So if it's pumping out all that blood, I don't know where that blood's going to go except back to the right ventricle. And so then the right ventricle is going to have to deal with that volume of blood too, so it's going to have to send it to the lungs, and that's going to go back to the left side. Okay, so you have to have the same volume being moved through all of these. And think about what happens. Let's say, okay, let's say our left side, I'm going to switch down to this better looking heart down here. Let's say the left side doesn't pump out as much blood. Okay, so it's going to the lungs, but it doesn't pump out as much blood. Well, here's our right side that's still pumping out a whole lot of blood to the body. Well, eventually, like I said, it's going to end up coming back to the right side of the heart. And if it's getting clogged up and this ventricle is kind of weak and it's saying, you know, I'm doing the best I can, the left side is going to say, yeah, well, you know, I don't care. There's your blood. You're going to have to deal with it because the body needs it. And the right side is saying, oh, you know, I can't produce as much. Then you're going to have, it's going to back up. Okay, you're going to get that congestion. It's like traffic moving in, and then you're going to have congestion. You're going to have a backup of blood flow, which is going to cause edema. Okay, so this is going to cause edema more in the mid regions or somewhere in the body, maybe in the extremities when you're standing up. So you're going to have backup there. Now, if on the other hand, okay, so let's just draw a heart that looks kind of like this. Okay, if let's say the left side is working fine, it's sending it out to the lungs. And then I guess we can change that to red, and then it goes back to the right side. Okay, but this is where most heart failure happens, is in the left ventricle. And so if this is our left ventricle over here, and it's getting this blood back from the lungs. It's saying thank you for the blood, and then it tries to pump it out. Okay, it tries to pump it out, but it doesn't pump out very much. Okay, if it's weak, then it's not pumping out enough blood. It's a closed system. So that means that the right ventricle is saying, there's your blood, there's your blood, there's your blood, and the left ventricle is failing. And it's trying to pump it out, but it can't get it out. And so what happens? The blood is going to get backed up. And where is it going to get backed up? It's going to get back up into the lungs. Okay. All right. So that's it. That's we're going to go over those things. Sorry, I didn't mean to get you excited thinking that the slides were over. Not even close. But that's what we're talking about. We're talking about left-sided versus right-sided. Okay. So if left and right must maintain equal outputs, if stroke volume on one side is less than the other, then blood will accumulate. And can you predict where accumulation will take place? I hope so, because that's what you're going to do on the exam. All right, so failure usually starts on one side, but will ultimately affect both sides. All right, so let's first talk about left-sided or left ventricular heart failure, decrease in peripheral or systemic blood flow, and a progressive accumulation of blood in the pulmonary circulation. Okay, so if you're not able to get rid of the blood, I'm going to make that a different color. If you're not able to get rid of the blood from the left side, then it's going to back up into the lungs. Okay, so that's where your backup is going to happen. So blood is still flowing in there, but it's not getting taken care of in the left side. So, decrease in peripheral, let's see, accumulation of blood in the pulmonary circulation. So, either the left ventricle doesn't accept enough, okay, so that means that maybe our mitral valve isn't letting enough blood into it, and so that's causing the backup, so it could be happening from there. Or, so right here, here's our mitral valve, maybe it's not doing it. Or that the muscle itself, it's going into the left ventricle, so you have your end diastolic volume, but it's not being pumped out right. Okay, and so it backs up into the lungs. Okay, so filtration pressure in the lungs exceeds capillary osmotic pressure. Okay, so what are we talking about? Remember this. Okay, So this is our filtration pressure is the movement of fluid out, but then it moves back in because of all of these colloids, okay, that are in here. All right, so it's supposed to be flowing like that, but instead the pressure tends to build up. The right ventricle is still saying, oh, here's more blood, and this is saying, yeah, no, too much. And so the fluid will collect out here. Okay, so filtration pressure in the lungs exceeds capillary osmotic pressure, blood gets backed up, the lungs congest. Okay, the lungs fill with fluid. And that, of course, means that that fluid that's supposed to be available for everyone is now in the lungs, causing problems in the lungs, and that means the rest of the body doesn't have it. Okay, so causes, most common causes are, of course, hypertension. Okay, when you're talking about the vascularization, you're talking about the tubing. Tubing gets full, can cause a problem. Myocardial infarction. Okay, our left ventricle isn't pumping the way it's supposed to. If it's not pumping the way it's supposed to, it's not getting rid of the blood backs up into the lungs. So an MI could cause, or any other kind of damage to the myocardium, could be a contusion, anything. Hypokinesis. Hypokinesis just means you don't have the right movement, or you don't have any movement in a certain area, okay, of that ventricle, the left ventricle. Okay, so rapid onset of pulmonary congestion and pulmonary edema. So other causes of left ventricular heart failure are valvular defects, stenosis, or regurgitation of the aortic or the mitral valve. Somehow you're not able to push the blood out. Okay, for whatever reason you're not able to get the blood out of the left ventricle, or you're not able to get the blood into it. It's whatever's causing it to back up into the lungs. Incomplete filling or emptying, so it doesn't fill completely, which is a preload problem. That's going to be more blood moving in, or emptying the afterload, that's not able to get the blood out. Both of these can lead to a lower stroke volume, even, okay, and we already went over that, even if the actual ejection fraction doesn't change. Okay, so that tends to be diastolic. We don't have enough blood, so if the injection volume doesn't change, it's going to be more preload. Okay, so what are we talking about? Pulmonary edema. Capillary fluids move into the alveoli. Okay, so normally we have blood that flows in, okay, to the lungs. So that's what we see here. Blood is flowing into the lungs, and we have some perfusion. Some of it filters out, and then it comes back in. Okay, all right, and then it goes back wherever it's going. So this is blood flow that's actually giving the cells of the lungs blood. Okay. All right, so that's normally what happens. Well, if you're not they're giving oxygen to the blood. All right, so if you have too much pressure here, which this is giving numbers, 10 millimeters versus now it's greater than 25, then you're going to have blood that's moving out. Fluid and blood cells. Okay, so you kind of have a breakdown of the capillary permeability, and fluid will move out, proteins can move out, and some blood cells can move out. Okay, and so that's if you have an excess filtration fluid, then all this fluid now is out here when it's supposed to be able to move back in, and it's not all going to go back in, and it remains out there. So the lung becomes stiffer. Yeah, the lung becomes stiffer if you think of our alveoli, and it's got the water in there, and so now we have more fluid, and so that fluid is going to hold it. It's going to hold it cohesive. It's going to hold those alveoli shut a little more, and it's going to be harder. It's going to be less compliant. The lungs are going to have a harder time expanding, so it's harder to inhale. There's going to be less gas exchange. I mean, it's kind of hard to have gases move across the increase in fluid. That's both in the capillaries, and there's going to be fluid between the capillaries. There's going to be more fluid everywhere. Okay. Crackling, frothy pink sputum can be generated, so coughing. Hemoglobin is not going to be completely oxygenated because you're not going to be able to get the oxygen through that mess. Okay, that's been created. Okay, so right-sided, a little bit different. Now, when we have the right side that's not getting rid of the blood, then the blood that's coming back from the body saying, yo, hi, right side of the heart, send me to the lungs, and the right side of the heart is saying, yeah, I'm not really able to do that as well as I would like to, and so what happens? Backup, congestion. Okay, so you get too much blood backing up, but this time it's on the systemic side. Okay. All right, so impairs the ability to move blood from the systemic venous circulation, leading to increased systemic blood pressure and peripheral edema. This blood is going to back up. It could back up into the digestive tract. It could back up into the kidneys. It could back up into the trunk and the lower limbs. So it backs up into the liver as well. Okay, so the right ventricle does not accept enough blood from the body. The right ventricle does not pump enough blood to the lungs. So it's the same thing. If it doesn't matter that if your tricuspid valve isn't letting the blood through, so if we have stenosis here, that can cause a backup. It really doesn't matter. Whatever's causing the backup, it could be that the heart muscle is weak, could be that the semilunar valve, the blood moves out, but if it's insufficient and some of the blood moves back in, it's just not able to pump it out here. This is the problem. We can't get it out. We can't get enough blood moving out, whether it's not full enough or whether it's blocked. Okay. Could be diastolic or systolic. So I'm kind of taking advantage of the fact that you probably by now understand diastolic versus systolic. So either way, blood backs up, body fills with blood, the lungs don't oxygenate enough blood because it's not getting to the lungs properly. So causes of right ventricular dysfunction, and here's where the issue is. Usually, most of the time, right ventricular dysfunction results from the left ventricular failure. Okay, so you have left ventricular failure, the right ventricle then gets backed up, and that can cause failure of the right side. Okay, so results from left ventricular heart failure due to increased pulmonary volume, putting a burden on the right side of the heart. Okay, once we have you could have lung congestion for a while, and then the right side starts to fail. The right side starts to fail, and then you have backup into the systemic circulation. Okay, so isolated right ventricular dysfunction is less common, but includes lung disease, so something that's causing fluid buildup in the lungs. Pulmonary or tricuspid valve disease, a right side, myocardial infarction that happens on the right side could cause damage to that right ventricle as well. Okay, so right side failure leads to edema, and it's position dependent. If you're standing, okay, then that edema may flow down into the lower extremities. Okay. If you're laying down, then it may tend to pool more in the mid regions here. Okay. All right, so right-sided failure leads to edema, which is position dependent, and congestion of the viscera. So hepatic congestion, okay, pooling in the GI system, and we may see weight gain from fluid collection or ascites. So fluid may build up in the around the tissues of the peritoneum. Okay, so manifestations of heart failure: right ventricular congestion of peripheral tissues, dependent edema and ascites. Okay, dependent on position usually. Liver congestion, signs related to impaired liver function, GI tract congestion, anorexia, GI distress, weight loss. That's right side failure. Left side failure, you can see that this is going to have a lot more. So the left side failure had a lot to do with the edema and the buildup of fluid in certain places. The right side you're going to see is more pulmonary in nature. So decreased cardiac output, activity intolerance, and signs of decreased tissue perfusion. So we have less less oxygen, less ability to move it to the body. Impaired gas exchange, so cyanosis, turning blue, signs of hypoxia. Um, Pulmonary edema, cough with a frothy sputum. Okay, so again, um, uh, pulmonary or related to the lungs, paroxysmal nocturnal dyspnea, or difficulty breathing at night when you're laying in a certain position. So okay, all right. So let's see. So heart failure manifestations overall, fluid retention and edema. So nocturemia, nighttime urination, oliguria, small amounts of urine. So let's reconcile these. If you have small amounts of urine during the day, okay, so this is actually kind of interesting. I didn't explain it very well in class. During the day, you might have edema, the fluid, because you're standing. I shouldn't say during the day. It has nothing to do with where the sun is, but it has to do with your position. If you're standing, you may have buildup of fluid in your lower extremities. And then when you lay down, so that's going to decrease small amounts of urine. You're going to have a fluid pooling in your extremities, which is going to decrease the amount going to your kidneys. Let's say your kidneys are way out there for some reason. Okay, so then when you lay down, that fluid may start to move up. Okay, it may start moving to the rest of your body, which is going to increase the amount of fluid that your kidneys are going to see, possibly. So that means at night, you're going to have more urination. Okay, so that's actually kind of an interesting little effect there. Respiratory dyspnea, labored breathing, exertional dyspnea. So when you're working harder, yeah, you're not going to be able to get the blood flow. Orthopnea, shortness of breath when lying flat. Okay, paroxysmal nocturnal dyspnea, sudden shortness of breath at night. Okay, so that has to do with position as well. So fatigue, weakness, mental confusion, loss of weight and muscle atrophy, malnutrition, cyanosis, arrhythmia, and of course this one, which is very bad, sudden death. That's certainly a manifestation to be concerned with. All right. So compensation, we've already gone over the Frank-Starling mechanism. It tries as hard as it can for a while. As more blood builds up, it tries to contract more forcefully, so more blood. Higher end diastolic volume automatically causes a stronger contraction, so more is pumped out to match, which causes a higher stroke volume. Our autonomic nervous system, okay, sympathetic division increases rate and contractility, okay, and the parasympathetic is going to decrease the rate and contractility. So remember that is a compensatory mechanism. The renin-angiotensin-aldosterone mechanism, when that is activated, it increases volume and pressure. So if perfusion, remember, the big problem is when the heart starts failing, it's not pumping enough blood to those cells. Those cells aren't getting enough blood, enough fluid, okay, to perfuse them, for that fluid to move around them. And so that interpretation is going to get back to the kidneys, which are going to release renin, and they're going to increase the fluid volume, okay, overall. Okay. All right, so sometimes heart failure is not detected until later stages because these compensatory mechanisms can mask the symptoms. All right, so treatment, non-pharmacological, exercise and training, low sodium diet, which is going to keep the fluid buildup from happening, lower blood pressure, fluid restrictions. Pharmacological, diuretics, that's going to decrease your fluid volume. Okay, and that's the most frequently used. ACE inhibitors block the RAA, or the renin-angiotensin-aldosterone pathways. Beta blockers, which block your sympathetic compensatory mechanism, so that's going to lower your blood pressure as well. Digitalis works on calcium in a roundabout way. You can cover that in pharmacology. Vasodilators. Vasodilators are going to allow the blood that you have, and that's going to lower blood pressure. It's going to allow the blood into the vesicles. or into the vessels, sorry, because the um, sympathetic activation is going to cause vasoconstriction, which can also lead to a reduction in perfusion. So vasodilators can open those up as well. Okay, which ACE inhibitors are also going to lead to some vasodilation. All right, circulatory shock is the next thing we're going to cover. It is an acute, so that means fast onset, rapid progression, acute failure of blood vessels to supply tissues and organs with blood. Okay, so we're moving out of heart failure, and now we're sort of focusing on the vascularization, and we're focusing on perfusion of getting oxygen to the blood or to the cells of the body. So it's an imbalance between oxygen supply and demand, and we're talking about demand by the cells. So hypotension is usually present. Okay? Usually the blood pressure falls. Your mean arterial pressure drops. That's usually what happens. It is possible that vital signs could be normal. It depends on if it's a redistribution of blood. Maybe one area is not getting blood, but another area is, which means your overall blood pressure may not change, even though the patient is undergoing or suffering from shock. Okay, so maldistribution, that means that the distribution is not the way it's supposed to be. It's going to the wrong places, or too much blood or not enough blood is being directed to certain areas. Inadequate oxygenation, so that's going to either way, if we have inadequate oxygenation of cells, tissues, or organs, okay, so that's going to be a problem. Alterations in cellular metabolism, so if you don't have enough oxygen, you're going to have an alteration in cellular metabolism and function, and this is going to cause more damage. Anaerobic metabolism causes a spike in lactic acid. If you don't have, this is important to understand, if you don't have enough oxygen, your cells still need to make ATP. Okay? And when they make ATP by anaerobic mechanisms, one of the things they make is lactic acid, which goes back to the kidney or the liver to make more glucose. So when someone is undergoing shock, you can measure lactate levels in the blood, and you can sort of see the progression, or you can see if a treatment is working by measuring those lactate levels. Okay, all types of shock share compensatory mechanisms and are designed to restore blood volume. Okay, so these are all designed to restore blood volume. Tachycardia, or at least perfusion, the volume, the perfusion volume, getting blood around the cells. So tachycardia, I guess we couldn't say that really restores blood volume, but it does increase the perfusion of the cells, so it gets oxygenated blood to the cells more quickly. So maybe I shouldn't have underlined that as thickly as I did. But for the most part, that's blood volume. And from the perspective of the cells, they're thinking they're getting more, or at least better fluid. The RAA pathway, so that's renin-angiotensin-aldosterone pathway, conserve water and sodium in the kidneys, and then thirst. Thirst is going to you're going to want to replace volume. So when we're talking about shock, most of the time we have some kind of volume or distribution of volume problem. Okay, so circulatory shock can spiral out of control because tissue damage from inflammatory processes further alters microvascular processes and blood flow, ultimately leading to organ damage. What does all that mean? That means that we have inadequate perfusion, which is going to cause hypoxia, which is going to ultimately damage cells, lactic acid. It's going to cause other effects like lactic acid accumulation. Blood is going to become acidic, which can then damage cell membranes, which damages more cells. Intracellular lysosomes release digestive enzymes. You have toxic substances now that are entering circulation. Okay, so all of these things are just sort of compounding to you don't have enough blood or you don't have enough perfusion, so you're not getting enough oxygen, causing more cell damage, which requires other which causes more damage, which then damages more cells. Capillary endothelium damage. Now we've damaged the blood cells themselves, or the blood vessels themselves, and so that's going to cause even more cell death. Okay, so it spirals out of control. We don't want to have too much time without proper perfusion. Okay, types of shock. Hypovolemic, it's just kind of, I guess, what it sounds like, low volume. Okay, you don't have enough volume. So loss of whole blood, loss of plasma, loss of extracellular fluid. Obstructive, for whatever reason, the heart isn't able to, so inability of the heart to fill properly or outflow. Somehow the heart is not able to get enough blood to move out. That's different than cardiogenic. Cardiogenic means that it actually is generated from the heart. So obstructive is usually something like cardiac tamponade. That means that here's the heart there, and maybe the heart is working okay, but it's not able to expand the way it's supposed to expand. Okay. All right. So, or obstruction. So it's trying to flow out, but maybe the lungs are congested, and so it's not able to move blood. Cardiogenic means that there's something wrong with the heart. Okay, so myocardial damage, myocardial infarction, contusion, something has damaged the heart itself. Sustained arrhythmia, so it could be an electrical problem, which could come from, any number of things can cause arrhythmias. A lot of times it's just electrolytes, but not always. Acute valve damage, so again, a heart problem. Ventricular septal defect, so the heart isn't moving the blood through, it's cheating and moving to other regions. Shouldn't say cheating, but because it doesn't want to, but it's leaking into other regions. Cardiac surgery. Distributive, now we're talking about going out here into the blood vessels, okay? And now we've moved sort of out into the periphery, and the blood vessels are, whereas they're supposed to be vasodilated or vasoconstricted at just the right levels or just the right amounts. We call that vasomotor tone. How much are they constricted? How much are they dilated? Then that's messed up. So distributive loss of sympathetic vasomotor tone that can be caused by neurogenic. So your sympathetic, parasympathetic is not communicating properly. It could be because of presence of vasodilating substances in the blood. So anaphylactic shock is included in that. Some kind of toxin is causing vasodilation. Presence of inflammatory mediators, septic shock. Okay. Oh, sorry, anaphylactic would be an allergic response. Septic shock would be a pathogen of some sort or an infectious agent. Okay, so this is a visual, and so these are on each of the next slides. So cardiogenic, the heart fails to pump blood adequately, so you have a decreased cardiac output. Decreased cardiac output, okay, so we just went over that with heart failure. Decreased cardiac output lowers blood pressure. Okay. Compensatory mechanisms, the sympathetic nervous system response, which can increase heart rate. Vasoconstriction increases resistance to blood flow. That's going to increase your blood pressure. Okay. Increased workload on the heart worsens heart failure, and manifestations going to be cyanosis. So if your heart is not functioning, okay, because this is all about the heart not working right, not doing what it's supposed to be doing. Cyanosis, lower blood pressure, lower urine output, okay, because maybe blood isn't moving into the kidneys the way it's supposed to. Poor cerebral perfusion, okay, so it's not moving to the brain the way it's supposed to, which can cause neurological changes. So cyanosis makes sense. You're not perfusing enough blood, so cyanosis is just sort of this turning blue, low blood pressure. All right, cardiogenic. Hypovolemic. Hypovolemic shock, inadequate circulating volume. Now we're talking about something where you have lost blood. Okay, so the blood just isn't there. Okay, so that's going to, if the blood isn't there, it's not going to be able to perfuse the tissues. Symptoms manifest when volume is decreased by about 15%. And I have here donating blood. You may decrease your blood volume as much as 10% without any problems. When it gets to over, this is the general rule, most of the time, is decreased by about 50%, 15%, sorry, 15%, then hypovolemic shock could ensue. So the pathogenesis: external loss of whole blood, trauma, or hemorrhage. Loss of plasma and extracellular fluid, which could come from burns, um, severe dehydration, vomiting, diarrhea. Okay, so anything where you're all of these things, you're losing fluid. Burns, you have the exudate that's constantly oozing out, and that's volume. That's volume, and it can really make a big difference. Fluid may be shifted from vascular to interstitial. Okay, so we could have leakage of fluid into the pleural cavity or something like that. It's moving. Fluid is moving into a place where it shouldn't be in such high volumes. Well, if it's moving into a different area, a third cavity we call that. But if it's moving into a different area that's not circulation, then, well, obviously, like I just said, it's not circulating. Decreased perfusion. Okay, obstructive shock, some kind of a mechanical obstruction to the flow of blood through the central circulation. Okay? Central circulation means those areas around the heart. Okay, so it could be dissecting aortic aneurysm. So we kind of talked about that. So in the aorta, there could be an obstruction of blood flow that's occurring there. Cardiac tamponade, we talked about that. That's fluid building up in the pericardial sac. A pneumothorax. Okay, a pneumothorax is when you have air building up around the lungs. Okay, so you have a lining. Let's see. You have the pleural lining around the lungs, and if you get air or something in that area, that can cause an obstruction. Pulmonary emboli, so a blockage of blood flowing to the lungs, okay, can cause obstruction. Okay, and then the last one is distributive or vasodilatory shock, distributive or vasodilatory. So we're talking about vasodilation. Okay, so remember that, vasodilation. Because I will say that all of the others, the cardiogenic, the hypovolemic, the obstructive, all of those others, the compensatory mechanisms will involve vasoconstriction. And we know that because the sympathetic nervous system is activated and the sympathetic nervous system causes overall vasodilation. In vasodilatory or distributive, we see vasodilation. Okay. All right, so if we have vasodilation, then now all of a sudden we have a lot more space for the blood that we had to begin with. Okay, so if we had a certain amount of blood and it was filling the vessels just fine, okay, and then those blood vessels suddenly get larger, well, you're going to have much lower pressure in there now. Okay, same volume of blood. All right, so not enough blood to fill the circulatory system, blood flow decreases. Okay, less blood is going to be returned to the heart, less blood is circulated to the body, you have decreased perfusion. So the types that we're going to sort of talk about: neurogenic, loss of autonomic nervous system function; anaphylaxis, okay, which is allergic; and septic, which is infection. Okay, so neurogenic, brain or spine injury, anesthetics, insulin shock, emotion. So that means that you have, let's see, this is your head. We'll put the spinal cord over here. Okay, so this is the spinal cord coming down. And that communication, we'll just have it going out like this, going out to the body. I don't know if this is a very good picture. But that's, and then you have your ganglion chain, so a lot of stuff that you may or may not remember. But either way, you have a signal coming out to tell your to kind of keep things either vasodilated or constricted. It keeps your blood vessels with the right diameter, the right amount of vasodilation or constriction. So what can happen is in a brain injury or a spinal injury, okay, then this signal may be cut off. Okay, so your sympathetic signal may be cut off, and then what may result is a lot of vasodilation. Okay, so your blood vessels may become more vasodilated, and that's going to be a cause of distributive shock. Okay, it could be, so that's brain or spinal injury. It could be anesthetics. So anesthetics may do the same thing, may interfere with this activation of the sympathetic nervous system. Insulin shock could do it. Emotion could do it. A lot of people will faint for various reasons, and it may be related to this distributive shock. Okay, so vasodilator substances in the blood, type 1 hypersensitivity. So that's the other one that we're going to talk about. That's another cause of distributive shock, inflammatory response to infection, sepsis. Okay. All right, anaphylaxis. Okay. Do we remember it's a type 1 hypersensitivity? Or it can be caused or it can result from a type 1 hypersensitivity. Systemic response to inflammatory mediators released in type 1 hypersensitivity. So things like histamine. Histamine's a big one. Okay? Cause vasodilation. Acetylcholine, kinins, leukotrienes, prostaglandins. All of these can cause vasodilation. Vasodilation decreases blood pressure, and that can cause decrease in filtration. So the lower blood pressure means that fluid isn't going to move out to perfuse the cells around there. Okay, so they can starve. All right, so what will happen when arterioles vasodilate throughout the body? Blood pressure drops. And like I said, and maybe I didn't say it well enough, but if we're concerned about our cells out here, so these are the cells, this is a blood vessel, the red is a blood vessel. If we're concerned about our cells out here, then we need to have perfusion. So blood needs to filter out here and perfuse those cells. It's not blood, but it's extracellular fluid that comes from the blood. Okay, so we need to have that perfusion. If we decrease our blood pressure, we decrease that perfusion. Okay, whoops, not sure why that happened. And I don't know how to now get rid of it. I didn't even know, in fact, that was possible to do. And I can't undo it. I apologize. That's going to be stuck there until I figure out how on earth that even happened. Okay, I hope it's not too distracting for you. It's kind of distracting for me. Okay, so weird. All right, so what was I saying? So yes, vasodilation is going to cause a decrease in perfusion, and that's of course what shock is. Okay, so what will happen when arteries vasodilate? Yes, decreased perfusion. All of these can, acetylcholine, kinins, leukotrienes, prostaglandins can also cause bronchoconstriction. What happens when we have bronchoconstriction? We have a reduction in, well, it's going to be harder to breathe for one thing, but we can also have a reduction in oxygen availability, lack of ability to get oxygen to the cells. Okay, so the last of these that we're talking about, the last of the types of shock, distributive. So this is distributive shock still. Sepsis and septic shock. So it's also called systemic inflammatory response syndrome, or SIRS, S-I-R-S. Okay, so this is the most common distributive shock, sepsis. Septic shock. Sepsis itself is an infection. So that means that some kind of infectious agent has infiltrated. So infection plus a systemic inflammatory response, because we know we can have infection that takes place, but it doesn't necessarily, it may stay local. So this is a case where it has gone systemic. We have fever, tachycardia, elevated white blood count. So we talked about sepsis before, I believe. And severe sepsis. So sepsis plus sepsis-induced organ dysfunction. So that's when we get to severe sepsis. We've got tissue hypoxia. Now we're starting to cause damage. And then finally, septic shock. Septic shock is severe sepsis plus hypotension. Our blood pressure has dropped. Hypoxemia. We don't have blood. We don't have we have low blood oxygen. We don't have enough oxygen. Oliguria, reduced urination, metabolic acidosis, high lactate. Of course, that's another marker that shows that that sepsis has taken place, and you can also see the progression, or you can see how well the treatment is working by measuring the lactate levels. Okay, so inflammatory mediators are released. So how does it happen? Yeah, we're talking about disease. We're talking about an infection. So inflammatory mediators are released into circulation. Tumor necrosis factor alpha interleukin 1 are a couple of those, and these will cause vasodilation. So there we are again with vasodilation. Vasodilation, lowered rapidly sometimes, blood pressure, shock. Okay. Decreased perfusion, shock. So cause systemic signs of inflammation, fever, increased respiration, vasodilation, and warm flushed skin. Okay, warm flushed skin. Okay, so you may not see those types of things with other types of shock. You may see more pallor, and here, when you have vasodilation, you may see warm flushed skin. Okay, so septic shock, vasodilation, vasodilation leads to decreased peripheral resistance. Okay, so that means the blood flows more easily. There's less resistance to blood flow. Decreased blood pressure, decreased perfusion, septic shock. Inflammatory mediators also increase the metabolic rate of tissues. So now not only are they not getting enough perfusion, but they need more oxygen. So again, that's part of that. This can really just downward spiral. Okay, 40% mortality. Okay, so the sources are usually respiratory. They can be GI, genitourinary. So this is where is the pathogen coming from? Where is this infection coming from? It's usually respiratory. A lot of times genitourinary. So like urinary tract type of problems. Okay. So most cases are from the hospital, so that's sort of why it's increasing, because people are getting more chronic treatments, more aging population, those kinds of things. So at risk, aged, critically ill, chronically ill, and of course immunocompromised. So anybody that can get an infection, and then you just have to put them in a situation where that infection can enter the body. So fast response is the key. So making sure that you see that it's happening, and keeping an eye on the vitals, removing the infectious agent, fluid replacement, vasopressors, something like obviously removing the infectious agent. But yeah, you need to, since you have vasodilation, giving more fluids isn't going to be a bad thing. Causing the vasoconstriction, so you want to sort of shut down that vasodilation, so vasopressors are used. Supplemental oxygen to help with the blood that is perfusing, and then of course a lot of these things are or all of these things really ultimately together are to prevent organ damage. Okay, so last thing we're going to talk about are the 5 complications of shock. So 1, 2, 3, 4, 5. Acute lung injury, respiratory distress syndrome, acute, so lungs. 2, kidney injury. 3, gastrointestinal, GI problems. Okay. 4, DIC, disseminated intravascular coagulation. This is the one where you have, we talked about that in I believe the first section, where you have an increase in clotting, and then all of your clotting factors are used up, so then you have I'm not sure what that is. You have an increase in bleeding. Okay. multiple organ dysfunction syndrome. So that's where all of your organs just kind of fail. So, acute respiratory distress syndrome, potentially lethal, exudate enters the alveoli. Now, let's see, so if we have movement of fluid, into the lungs, and then the lungs, that moves into the alveoli, then I think I think the problem is pretty, I don't want to say it's obvious, but when we have this buildup of fluid inside the alveoli and around the alveoli, okay, that's going to block gas exchange, obviously. Okay, so the oxygen is going to have a harder time moving through all of that, especially since oxygen isn't very soluble. Now, carbon dioxide, of course, we're talking about exchange, CO2, so carbon dioxide is going to be trying to move through that. So fluid blocks gas exchange, supplemental oxygen and ventilation, so that means helping with a ventilator, helping the patient breathe, may be given, but oftentimes it's not very effective, because a lot of times it's not so much that there isn't enough oxygen, it's that the oxygen isn't able to move. Now, it's still provided. I mean, increasing the oxygen and increasing the ventilation is definitely better than not doing anything. That means that maybe there's going to be a little bit more access, but a lot of times it's not as effective as we would like to see. Makes inhaling more difficult, so increased fluid means that these are going to be held together more. Neutrophils enter alveoli. The question is, what is causing this? Why is shock focusing so much on the lungs? And the thing is, we don't know. Okay, so the exact cause is unknown, but it likely involves neutrophils, which is why I was mentioning that. So because that's one of the things we see. We see that neutrophils will enter the alveoli. Okay, so they're squeezing through. Maybe it's an initial inflammatory signal, but they release inflammatory mediators, which release proteolytic enzymes, alveolar damage. It's an inflammation, so that means you have increased permeability. And so, yeah, you have this buildup of fluid in the lungs, okay? And so you can actually have lung damage that results from shock, okay? And that's what I forgot to mention. This shock not only stops the machine, but it wrecks the machinery. So that's why we need to talk about the complications, and why it's not just a matter for shock to end it, because going into shock itself can be damaging, but the whole time that particular person is in shock, it's potentially and most likely is causing some kind of damage, and some of that you may not be able to recover from that. Okay, so acute kidney injury. So renal vasoconstriction cuts off urine production. Okay, so this is why why thirst is a big thing. Dehydration, thirst. Low blood pressure is going to cause you to want to retain more fluid. So cutting off fluid to the kidneys takes out that entire system. Okay, so like 20% of your cardiac output is going to the kidneys. So if you shut that down, or at least decrease it a lot, that keeps blood in other parts of the body. But the trouble is, if you don't provide blood to those areas, that can result in acute renal failure, which means it can happen very quickly. Continued vasoconstriction can cut off renal oxygen supply. If you cut off renal oxygen supply, then these renal tubular cells can die, and you can have acute tubular necrosis. Now, there could be some level, if you can recover quickly enough, that you can have some you can bounce back, you can have some recovery, but either way, this can be a very serious problem. Okay, DIC, disseminated intravascular coagulation, and this is the one that we talked about with the when you start to have microvascular damage, maybe. The cause of it's not completely unknown, but a lot of times it's associated with trauma, sometimes in childbirth or something like that, where you have the formation of clots. So clot formation in many small blood vessels, microinfarcts. So micro, we're talking about small blood vessels, and we're talking about tissue damage. Okay. So ischemia, a reduction in blood flow to certain areas. And then if you have all of this damage and all of these clots that are forming, then the platelets and the clotting proteins eventually can be used up or severely reduced. And then you're not able to stop bleeding at all. And so then you end up with a bleeding problem. So this is a situation where a clotting problem, a vast disseminated clotting problem, so it happens all over the body, or at least all over in a particular region, can ultimately lead to a bleeding problem. So clotting problem advances to a bleeding problem. Okay, so other complications of shock: multiple organ dysfunction syndrome. Homeostasis is disrupted in multiple organ systems, including the kidneys, lungs, liver, brain, a lot of very important organs. Most frequent cause of death in the non-coronary intensive care unit. So that means someone goes into septic shock, even though they didn't have a coronary issue to begin with, then that can ultimately lead to mortality. Mortality rates vary from 30% to 100% depending on the organ involved. And of course, if it starts to affect the brain or even the heart, that's going to increase mortality. Okay, so what causes this to happen? Not exactly sure. Some kind of overall imbalance, inability to maintain that homeostasis, and things just kind of, again, they start to spiral. Okay, and they just sort of go down. Okay, that's it for this section, and that's it, I believe, for the cardiovascular system.